All righty. It's a pleasure to talk with everybody in these trying times. I know that this is a difficult period for everybody as we try to wade through what is currently going on throughout the globe and certainly within the U.S. It is true that during this time, BPCI continues to go on. We know that there are changes in most locations, that elective procedures are being postponed to a later time and in favor of only emergent procedures, so on and so forth. And so with these rapid fire changes that have gone on, we would like to, and you can stop the slides right there, we would like to just talk about changes that have happened in terms of waivers, the waivers that are in existence now for BPCI Advanced, that have always been in existence for BPCI Advanced, as well as a lot of the changes that have gone on in the past week to week and a half that may be confusing to everybody in terms of what that implication is, what that means, how do they apply, do they apply at all, what is it that affects the normal run of what you're doing for those cases that are still active. And I know that this is difficult and there's lots of things going on. And so obviously, I will start this off, then I'm going to hand this off to Shawn and I'll add some color commentary as Shawn talks about the new changes that have come about in the last week to week and a half. I'm going to cover a lot of the areas that are indicated by the arrow right now on the section 1115A waivers, which are those that have always been in place for BPCI Advanced, and kind of recap exactly where those are, what those are, how those came about. And in that way, as Shawn goes and describes those things that are new, you can determine what those differences may be. You'll find that some of these things overlap to things that are already in BPCI, and other things are new changes that apply to BPCI beneficiaries as well as every Medicare beneficiary. One thing to keep in mind as we go through this entire presentation, you'll probably hear this several times, this is an evolving process. The information is evolving and it's doing so in rapid cycle. Not even just day-to-day changes, there are changes within days. So please keep in mind that everything that we're going to say today, especially in what is new, could change tomorrow or later this afternoon in some respect. We don't know when they happen until they come out from CMS and the federal government in the same manner that you do. So if you move on to the next slide, we're going to spend a little bit of time here just talking about the BPCI-A waivers, what the waivers really mean, and what you can still end up doing with these for the beneficiaries that are in active episodes. And I say active episodes, understanding the differences between emergent and previously scheduled or elective procedures and things that are changing. So if we look at this slide on the top half where we have the waiver examples, these are waivers that can be put into place by Section 1115A of the Social Security Act that the Secretary of Health can apply. CMS and the Innovation Center have applied these waivers as part of the BPCI Advanced model. On the upper left where it says BPCI default, it talks about ICS and internal cost savings, NPRA sharing, the SNF, 3-day SNF rule, discharge home visits. Okay, these have always been in place. They're available for everybody to use. Internal cost savings, of course, is a process that has to be engaged in with the episode initiator and their hospitals, if they so choose to. They do take some time to being set up. That's a process that we were really looking into rekindling at this time. And obviously, given the current situations, that will be delayed, I think would probably be the best term. For some period of time until we get over this particular set of issues. Everyone is more concerned with other things other than trying to put together ICS agreements. Okay, but basically ICS is where you can work with your hospital to save internal costs and you can share in those savings. That's what the base premise is based on. NPRA sharing is obviously the sharing of dollars that come in when there's positive reconciliations. I know everyone's hoping for positive reconciliations, or any reconciliation for that matter, but these are processes that are in place for any of the reconciliation periods of time. The 3-day SNF rule is the same as it has always been for BPCI advanced beneficiaries. For any beneficiary that has an inpatient stay, not outpatient procedures, inpatient stay, you can send them and utilize a SNF with less than the normal 3-day qualifying stay that would have normally existed. That is still true. The SNF has to be recorded on an approved SNF list based on being 3-star or better in 7 of the last 12 months as a rolling number. And those SNFs come out on a quarterly report that CMS puts out that indicates which SNFs are eligible for utilization of the waiver. There's a second complicating factor that an agreement has to be done. That's a written agreement between you, the EI, us, Fusion 5, and the SNF in order to have that done. That's just an agreement that CMS now requires for one reason or another. But that's still there. It has not changed from what it is before. You will hear Shawn talk about additions to that as we go forward. The same is true for post-discharge home visits. They have been allowed in BPCI since its inception at the beginning of 18. There is some new information on the utilization and application of post-discharge home visits for people beyond the BPCI portion. Beneficiary incentives are really what exists on a majority of the remainder of this slide: the care modalities, equipment and tech, indirect services. These are all beneficiary incentive waivers, and the same rules apply. All of these are possible in order to come out, things that can be supplied to beneficiaries that are generally paid for out of savings. And then the reason that they incur savings is you're not having a higher cost component in part of patient care. You reduce that cost, it becomes savings, and you can then pay for a different type of incentive that achieves the same goal for the patients at lower cost, and that's and for something that currently isn't billable through Medicare. The one caveat to any beneficiary incentive waiver is that it must fit at least one of 5 clear guidelines in order to be furnished. And that is, it either needs to be a preventative care service, needed for adherence to a treatment regimen, needed for adherence to a drug regimen, needed for adherence to a follow-up care plan or the care plan that is generated, or management of a chronic disease or condition. And there's lots of room and gray area in that. We have supplied a library of available waivers that can be used that fit at least one of those criteria, and some of them are indicated here in each one of these categories. I don't need to go through them. You can read them just as well as I can. Any other waivers that come to mind that might like to be used that are not part of something that we've already put out, feel free to send in to us so we can review and determine whether we believe that they actually fit one of the 5 major categories. And then you, in fact, are free to provide those services, knowing that you would be paying for them up front and recouping those costs out of savings and a reconciliation period. Okay. The real key here is proper utilization. You want to use these when you can provide proper patient care using them. The patient always comes first. And also incur a lower cost while providing those services to the beneficiaries, so that you can incur savings relative to what would be a normal or more traditional historic perspective in terms of what is going to be done. Virtual physical therapy is a great example of that. Sometimes it's not possible to have local physical therapy, or it's more expensive to do it in a remote location where it's not your physical therapy services that are being done, but somebody else's. You're not quite sure of the quality of the therapy services as well. Are they really working towards the best interest of the patient, or is this more of a revenue cycle for them? virtual physical therapy services are available. There's something that is put in with the patient in their home and they do them remotely with a live PT on the other end. Those type of things can be less costly and more effective for the patient in certain circumstances. And the circumstances are one that does have to be considered during all of this that goes on. In terms of waiver compliance, the real key is none of these waivers are exhaustive. They are uses at the discretion of the episode initiator. You want to take into account what this means for the beneficiary, the quality of care, patient outcome, as well as are you really saving costs. Overutilization of waivers can actually cost you more than some of the services could. So it's a mindful analysis that needs to be done on what is the best utilization of these type of waivers for the patients in terms of the BPCI program. Okay, we talked about criteria and justification for each waiver type. You know, communicate with us if there's something that does not exist in the listing that you should have already received quite some time ago. It is a good idea to keep records of usage of beneficiary notification or beneficiary incentive waivers. A while back, there was an incentive use record that was made available that should be used. There is no current reporting for CMS that is done for utilization of these waivers. This is a divergence from BPCI Classic, but it's a good idea to keep them. It doesn't mean that CMS or their third-party analysis people will ask for them in the future and ask for them retroactively back to some period of time. I'm hoping that doesn't happen. It's not going to happen in the short term with all of this other stuff going on. But it's a good idea to keep the records, especially for cost accounting. You want to know, since you're paying up front for these, what that cost is so that you know what to retain from savings as a direct cost and then figure out what remains after that. I think that's going to cover what I wanted to talk about in terms of the current BPCI advanced waiver contingent and how it applies. Literally nothing has changed relative to the way BPCI advanced works. Now, what you're going to hear in the next set will be something that Shawn Matheson will discuss, which is those things that are new within the last week to week and a half, Section 135 waivers and the 1812F waiver that was put in place that pertains mostly to SNF. So Shawn, take it away.
Can everybody hear my audio okay?
You sound great.
Okay, great. So I'm glad we could level set on that prior section on BPCI-A waivers. The irony of these new emergency waivers is many of them are actualizing the waivers that we already have in place with BPCI-A. So as an episode initiator, we recommend that you continue to make use of the BPCI-A waivers, but we provide this information for you to have on hand by reference, should you choose to use these emergency waivers. Bear in mind that these are just that, emergency waivers, and they're used for purposes of getting through this COVID-19 pandemic. These do have statutory precedence under Section 1135 of the Social Security Act, given that President Trump on March 13th declared the national public health emergency. That enabled the statutory powers of the CMS, or excuse me, of the HHS secretary to allow CMS to have more waivers with the idea that they wanted to have temporary relaxation of current standards in order to make hospital beds available. So these are temporary in nature. Typically, these are going to be 60 days. That's what's coded into law. But it is also in the law that the secretary can have that authority to extend any waivers as she or he deems necessary. Some of these waivers that we'll talk about are blanket, meaning national, and then others are going to be on a case-by-case that you implement. So with that in mind, we'll go forward to the next slide, and I'll start to talk about the blanket, and then we'll get into the case-by-case. On the former, I'm going to just give a brief list here and just a brief overview of what some of these waivers are. And again, bear in mind that these waivers can apply to all of your Medicare beneficiaries. These are not just limited to BPCI-A, such as the waivers that we have under our statutes. So critical access hospitals, you're likely familiar that they normally have a 25-bed limit, and then their average length of stay needs to not exceed 96 hours. That is a waiver should those CAHs need to free up more bed space or keep a patient longer for care. The housing of acute care patients in excluded distinct parts, if you have a portion of your hospital that is not licensed for these emergent situations, and with your proper documentation, you can free up or you can place patients in those distinct parts of your hospital, not yet licensed. These are really two waivers, this third bullet point, that I put into one. As a hospital, you can place patients that are currently in your inpatient rehab or in a psychiatric unit back into acute care if you needed to free up beds in that acute rehab or inpatient or the psychiatric unit. Durable medical equipment had some interesting developments that were announced that they, for a period of time, are waiving the face-to-face requirement and the medical necessity of the orders. That's with a giant caveat that that is only if the documentation is lost, requiring those elements, and if those documents were lost secondary to an emergent situation. There are provisions for LTAC hospitals that they can exceed their 25-day average length of stay requirement. Home health agencies saw some easing regarding their OASIS submission timeframes, which is their patient assessment instrument. Also had some easing that the MACs could extend some relaxation of the auto cancellation dates for their requested anticipated payments, their RAPs. And then lastly, on the blanket waivers, if a provider needed to come to another state, this could be a hospitalist example, is not yet licensed, this waiver helps those providers be able to provide those services, not yet being individually licensed. So let's move forward to the case-by-case waivers. These are much smaller in nature. These would require you as a provider to seek specific relief and permission from your MAC and your other fiscal intermediaries that you interact with. So there is some relief for the emergency, the EMTALA Act of 1983. So if you do need to transfer patients that are not yet stabilized for this emergent situation, you can. Stark laws, if you needed to make referrals that would otherwise fall into that category, again, you can apply with your MAC and contact through Medicare. There are some HIPAA requirements that are being temporarily relaxed as well, again, just secondary to emergency situation, not blanket in nature. So if you needed to speak with a family member and don't yet have that patient's permission, if you haven't yet distributed your notice of privacy practices. And lastly, and we'll talk about this more on the next slide, in telehealth, Medicare for a temporary period is allowing the use of smartphones and other non-secure devices if you're going to be discussing any PHI with patients.
I want to add, yes. I want to add one thing to this, and this is a good spot to remind everybody of this, and this is probably something that you will hear again as Shawn goes through, is that while these waivers are being produced by CMS and the feds for those rules, regulations, laws, whatever they may be called, they do not necessarily supersede state statutes or laws, and you need to be cognizant of the state rules, which will take precedence over any of these that may have changed. And so if you have individual state Stark laws, you will need to know what those are, and because they may or may not be relaxed, as well as any other HIPAA regulations and so on and so forth. So that needs to be something that that you have in the back of your mind as you think about all of these changes that have gone on.
Yeah, great points on that, Jerry. So on our next slide, we have two examples that, in our opinion, really affect BPCI episode initiators the most. These are in the blanket category, so they are national in nature. You do not need to seek specific permission from your MAC. The first dealing with SNFs, 3-day prior hospitalization waiver, and the spell of illness waiver. Now, we know that in the BPCI-A waivers, we already have the former, the ability to waive a 3-day prior hospitalization. This second, though, element is new, that for all Medicare beneficiaries, including BPCI-A or bundle attributed patients, there is some relief for spell of illness. So normally you have to have a 60-day window between each spell of illness. But if somebody, because of the COVID-19, had to extend within that 60 days, not have a full spell, then you can have that relief. There are some billing codes that the SNF would need to get into for this, and we can provide copies of CMS documents for that for the SNF if needed. But we've been following the American Healthcare Association guidelines on this. We're getting emails daily from multiple different sources, including the trade association. So that is something new, that spell of illness waiver. I would say, on a personal note related to SNF, though we are dealing with a COVID-19 situation here, naturally the situation doesn't change in terms of bearing in mind that we need to keep patients as safe as possible. SNFs are at particular risk. There's a good Kaiser Family Foundation article that came out on this last week in terms of the facility-acquired nosocomial infections. You've certainly seen in the news the unfortunate situation with the was it Kirkwood? I'm getting my town in Seattle, east of Seattle, mixed up. There with a SNF that had experienced a few deaths secondary to the COVID-19. So bear in mind infection control at this time. Home is the best place. And then one other note on SNF. Last week, Medicare did come out with requirements that limits the visitation to SNFs of non-essential healthcare workers. So you see families unable to visit and just really having those moments through the window. So do get people home as much as you can, and these waivers are in place for emergency purposes to free up hospital beds for those acute situations. Lastly, of note, related to our partners, we feel, is the telehealth waiver. So this does expand telehealth services. I personally wish Medicare would have come out with this years ago, and I'm hoping that this unfortunate situation will be the impetus for that, for this to be more permanent in nature. But Medicare did make available the ability for a physician to interact with her or his patient, and to do so remarkably with the use of non-secure HIPAA equipment, i.e. you can FaceTime and you can use those non-secure devices, so long as you're acting in good faith. There are some vendors certainly out there. One that we have worked with closely in the past is Ortho Live. He's a surgeon out of Ortho Cincy, a friend of Fusion 5. We definitely recommend you would contact him. For those of our partners who are orthopedic, that is a service that is specific. Certainly AMWell, Touchpoint, InTouch are some of the other top-rated class telehealth providers. I would recommend you go to KLAS, K-L-A-S. They're a great service that rates the different providers around the country. But I've seen 2 advertisements just in my inbox from telehealth providers really making an active push right now. So those are specific to us. Now with telehealth, you still have the BPCI-A waiver. So you could still be using this for your purposes of episode initiation and case management. On our next slide, we just want to summarize here that the Health and Human Services and CMS are using these new emergency waivers to accommodate these exigencies experienced by healthcare providers in this national disaster. So they're offering this broad spectrum potential relief. By statute, this is 60 days in nature, but the secretary can extend if needed. Now, really key to all of this with these new waivers is to consult your attorney, your coding professionals. There are a number of modifiers, for example, with, well, there is a modifier with professional fee coding that you'll submit on your CMS 1500. If you're a hospital on your facility charge, there is also a modifier code that's specific for you to submit. We can provide you with Medicare documentation, but please consult your network of professionals. And I believe we had one other slide next. This is a valuable resource. If you can screenshot this, or we can send you, we'll be sending you the PDF of this, and you can hyperlink, I believe, within the PDF. Bear in mind at the bottom, we have regular updates that we are releasing. We've had 8 just in the last 12 calendar days. We are every day, we've got 4 or 5 of us that are just monitoring different listservs. The most important information that we can provide to you is that which we will receive from CMMI regarding BPCI-A. They did provide last Friday a general announcement, and perhaps Jerry, you can talk about that.
Yeah, the general announcement, to be honest with you, did not say very much in detail. All it indicated is they are cognizant, certainly, of the issues that are affecting everybody, and they will continue to monitor the situation to determine what actions are necessary from their perspective for the BPCI advanced model. And that is all they said. We have no idea what that's going to look like, what it's going to pan out to be, and if it's going to pan out to be at this point in time. It seems pretty clear that CMMI is likely waiting for things to stabilize just a little bit in terms of the rapid fire changes, because otherwise they get caught in doing something at one point in time that changes the next day. So they may be patiently waiting for an appropriate time to figure out exactly what actions they may or may not take. But that's kind of where it stands right now. We will certainly keep everyone informed as we learn information specific to the BPCI advanced model, but there is nothing out of consequence yet to share.
On our next slide, we have a Q&A, and we'll open up the chat box here so we can see your questions. If you'd like to type those in, I'm not sure that we have the ability in this format to unmute. So we'll stand by here, Jerry and I, and await your questions. I believe there's a raise hand function as well within the Zoom on the bottom of your toolbar. While we're waiting for questions to come in, I just want to note that we ask you to please contact your regional directors at Fusion 5. We also have an email set up, questions@fusion5.us. That's funny. We have a question coming in by phone. Well, we'll stand by here just maybe 30 more seconds. That will give somebody to type, or perhaps even if you can just type in the chat box that you are working on a question.
Okay, a question came over from Sonia Galagos Kukin. It says, my hospital does not do waivers. Do you think this may change their mind?
Say the question one more time, Kristen.
Sure. It's from Sonia Galagos Kukin, and the question is, my hospital does not do waivers. Do you think this announcement may change their mind?
Well, not necessarily. I'm assuming that the person is from a hospital. Waiver utilization varies depending on who the episode initiator. It has in BPCI Classic, and it certainly does in BPCI Advanced from its inception in October of 18 to date. Utilization of waivers, certainly the beneficiary incentive waivers, is totally dependent on the EI and what their desire is. There are good reasons to utilize some waivers. I will admit that ACHs tend to be less likely than physician group practices to utilize them, but that's not an all or none by any means. Are they more likely to utilize the waivers with these changes? I can't certainly answer that question. My guess is not necessarily, even though they may take advantage of certain of the newer waivers that apply to all Medicare beneficiaries, certainly the SNF waiver. One of the reasons the SNF waiver that did not require a 3-day qualifying stay was put into place was to relieve beds within the hospital setting so that they could have open beds for actual perhaps COVID-19 patients and move others to a different facility as opposed to within the ACH. But that's still to be determined and is going to be very site specific.
Great, thank you, Jerry. We have another question that came in, or maybe a statement from Holly Menard saying, with the blanket for 3-day SNFs, this is automatic even if acute care hospital has not canceled elective surgeries.
Yeah, that is blanket and national in nature, regardless if the hospital has canceled elective surgeries or not. So this just provides the hospitals nationwide with an ability to free up beds if they need to. The interesting thing there, though, is even if they send a patient to the skilled facility, say after a 2 midnight stay, the patient still has to meet skilled nursing criteria. So Section 8 of the regulations for SNFs clearly identify those. We can get you a copy of those if you need. Patients still need to meet skilled criteria.
Wonderful, thank you for that answer, Shawn. Okay, no other questions have come in. We'll hold for 30 seconds to see if anyone has anything else. If you don't have any questions today, but think of any later, as Shawn said, please feel free to send your questions into questions@fusion5.us, and we'll answer those as they come in.
And again, as a reminder, we will be posting any information that comes from CMS and certainly from CMMI on the Fusion 5 website, likely under the COVID-19 update section.